Welcome back to the Doctors in Training Pharmacology Review course. In this lecture, we're going to be talking about diabetes mellitus and the use of insulin to treat diabetes mellitus. In your pharmacology book, whatever book you're using, there should be a section on insulin and the use of insulin to treat diabetes. If you're using Lippincot's pharmacology, it should be chapter 24. We will prompt you later on in this lecture to review the pages that correspond in your pharmacology review book to help augment your learning for this lecture. As today's lecturer, we have Dr. Mike McGinnis, who is a board-certified internal medicine physician and one of our chief educators here at Doctors in Training. I will see you again intermittently throughout the lecture to review some of the key points and add in some additional points that are high yield. So let's go ahead and get started. Dr. Mike McGinnis.
In this lecture, I'll give you some background information on diabetes in general. We'll talk about insulin. Where does it come from? What does it do? We'll talk about some specific types of insulin that we use. We'll talk about short-acting or rapid-acting insulin. We'll talk about intermediate-acting insulin and then long-acting insulin. And then we'll talk about how we use insulin. And I'll give you some important practical considerations that may not be found in Lippincot's. Now, diabetes is primarily a disease of the pancreas, so let's have a quick review of the pancreas. The pancreas, you recall, is both an exocrine gland and an endocrine gland. Now, the exocrine pancreas produces digestive enzymes, and it releases these digestive enzymes into ducts. That's what makes it an exocrine gland. And the ducts carry the digestive enzymes into the GI tract. And these digestive enzymes include trypsinogen, chymotrypsinogen, lipase, amylase. The endocrine pancreas involves the islets of Langerhans, or as we say around here, the islets of Langerhans. Dr. Langerhans was a medical student when he discovered these little clusters of cells scattered throughout the pancreas. The islets of Langerhans have three cell types. They have the alpha cells, which produce glucagon, the beta cells, which produce insulin, and the delta cells, which produce somatostatin. Now let's talk about diabetes mellitus. Diabetes indicates a situation where you're making too much urine, and mellitus indicates sweetness. Back in the old days, before we had the convenience of checking blood sugar and glucose in the urine, people would take the urine from a patient who had diabetes, or they were going to test the patient to see if he had diabetes, and they would see if that urine attracted insects, ants and flies and that sort of thing. That indicated there was sugar in the urine. In some cultures, they would actually dip a finger in the urine and taste it and see if it was sweet. And so that became known as diabetes mellitus, indicating sweet urine. In contrast, there's diabetes insipidus, in which the urine is insipid. It has no taste at all. Diabetes mellitus affects about 180 million people worldwide, which is about 2.5% of the world's population. That's expected to double by the year 2030. There are about 21 million people in the United States, or about 7% of the population in the United States, that has diabetes mellitus. And diabetes is associated with a huge burden of disease. It causes cardiovascular disease, eye disease, kidney disease, etc. There are two basic types of diabetes that we talk about, type 1 and type 2. We're going to talk first about type 1 diabetes. It is caused by the autoimmune destruction of the beta cells in the islets of Langerhans. So in your study guide and the table at the top, type 1 diabetes is caused by the beta cell destruction. Primarily affects children and adolescents and young adults. And the symptoms of type 1 diabetes are basically caused by high blood sugar. That blood sugar is filtered in the kidneys and excreted in the urine, and it causes an osmotic diuresis. So a lot of water follows that glucose into the urine, and these patients have polyuria. They urinate a lot. Because they're urinating so much, they're becoming dehydrated, so they get polydipsia, they get a thirst, they drink a lot of water. Because they're losing a lot of calories, they're losing weight, they may have polyphagia, meaning they have an increased appetite, a desire to eat a lot. And with loss of calories, they have weight loss. And then the final symptom of type 1 diabetes is diabetic ketoacidosis, or DKA, which is a complicated situation where they have very high blood sugar, they're no longer able to use sugar for energy, and they start creating keto acids, and that causes acidosis, and that can be life-threatening and very dangerous. The treatment for type 1 diabetes, these patients cannot make insulin. They have completely lost their beta cells. They cannot make any insulin, so they require exogenous insulin. They are dependent on insulin shots to survive. Then we talk about type 2 diabetes. The cause of type 2 diabetes is a little more complicated. In type 2 diabetes, the the patients may have functioning beta cells, but those beta cells are inadequate. They cannot produce enough insulin. And so in your study guide, on the column there on the right, it says the inability of beta cells to produce adequate insulin. The other main cause of type 2 diabetes is insulin resistance. These patients may actually have very high levels of insulin. They're producing a lot of insulin, but that insulin is ineffective. The body's tissues are just not receptive or not responsive to the insulin that they produce. Eventually, as the beta cells try to produce enough insulin and keep trying over months and years, the patient's beta cells basically poop out. They can no longer produce enough insulin, and then they get beta cell insufficiency. So they may start out with very high insulin levels and then eventually develop low insulin. This is primarily seen, type 2 diabetes is primarily seen in patients who are obese, patients who are aging. The older you get, the more likely you are to have beta cell dysfunction, and the beta cells just wear out like everything else does as you get older. And then genetics does play a role in type 2 diabetes. The symptoms of type 2 diabetes are essentially the same as the symptoms for type 1 diabetes. Polydipsia, polyuria, polyphagia, sometimes weight loss. Diabetic ketoacidosis is not nearly as common in type 2 diabetics as it is in type 1 diabetics. It used to be said that if you have DKA, you don't have type 2 diabetes, you have type 1 diabetes. That's not entirely true. We know now that some patients with type 2 diabetes do in fact get DKA, but it's much less common than in type 1. The treatments for type 2 diabetes are a little more broad. You have a lot more options. As I said, for type 1 diabetes, you have to use exogenous insulin. You have to give insulin shots. With type 2 diabetes, the number one thing is lifestyle modification. These patients need to lose weight, they need to exercise, they need to follow a better diet. All of these factors will help reduce insulin resistance. You can also treat with oral medication to either improve insulin sensitivity or improve insulin release, improve insulin secretion. And then finally, some patients with type 2 diabetes will require insulin. Usually this is people who've had type 2 diabetes for a long period of time. We used to kind of tell patients, if you don't take care of yourselves, you're going to wind up on insulin. We now try to stay away from that. We know that these patients are going to wind up on insulin if they live long enough. And our goal as physicians is to keep them around long enough to need insulin eventually, to not let them get so sick from complications that they die before they become insulin resistant. So let's talk next about insulin and the physiology of insulin, where it comes from, and how it's used. Insulin is a polypeptide. It's a protein. It's made of 51 amino acids, and there are a couple of important disulfide bonds. Insulin is synthesized as proinsulin, which is pictured, and these proinsulin molecules, the disulfide bonds are in place, and then the proinsulin is cleaved inside the cells to produce insulin and C-peptide. You can see that insulin has an A chain and a B chain, and then a separate C-peptide which has been cleaved. So we don't very often check insulin levels. That's not very clinically useful. But it is sometimes useful to check a level of C-peptide. There are a couple of situations where that might be useful. First of all is if you have a patient who's maybe 30, 35 years old, maybe a little bit obese, and they're newly diagnosed with diabetes, and you want to find out if they have type 1 or type 2 diabetes. Well, if you check a C-peptide level, that can be very useful because a patient with type 1 diabetes is not making any endogenous insulin, not making any C-peptide. So that patient should have a low level of C-peptide. A patient with type 2 diabetes, as I said, they're going to have very high insulin levels. They're going to have a lot of C-peptide. So they would have a very high C-peptide level when you checked. So that's one instance you might find it useful to check a C-peptide level. The other instance is if you have a patient who's developing hypoglycemia and you're concerned that they may have factitious disorder. They're giving themselves insulin. Maybe it's a healthcare worker, a nurse or a doctor, and you think they might be giving themselves insulin to lower their blood sugar and cause hypoglycemic symptoms. Well, if you checked that patient's C-peptide level and it was very high, that would suggest that they're actually making a lot of insulin. They may have an insulin-secreting tumor, an insulinoma, and they don't have factitious disorder. If, on the other hand, that patient had a low C-peptide level, it might suggest that, in fact, they're not producing a lot of insulin and they're actually might be injecting insulin, so they have factitious disorder. Because the insulin that you buy in a bottle at the drugstore does not have C-peptide in it. Let's talk about insulin secretion. There are lots of things that stimulate and regulate insulin secretion. And if you look at number 2 on your study guide, it says, how is insulin secretion regulated? The three things I want you to remember: glucose is the number one thing that regulates insulin secretion, certain amino acids, specifically leucine and arginine, and then digestive hormones, glucagon-like peptide 1, which is called GLP-1. There's another hormone called GIP, glucagon, cholecystokinin. These are all digestive hormones that regulate insulin to a certain degree. Now, insulin secretion is kind of complicated because there's always a little bit of insulin secreted. It's called what we call the basal insulin, sort of a low-level, constant amount of insulin that's always being secreted. But then we see the glucose levels rise with meals, and the insulin levels rise with meals to keep those blood sugar levels under control. We call this the prandial or mealtime secretion of insulin. That's an important concept, an important term for you. Prandial means mealtime, so we talk about preprandial, before mealtime insulin, and postprandial or after mealtime insulin. So we're looking now at a schematic drawing of a beta cell. And here we see glucose entering through a glucose transporter, and these glucose transporters are found throughout the cell membrane. But glucose enters the cell, and the glucose is metabolized to cause a rise in ATP. The rise in ATP closes these potassium channels, which allows the cell membrane to depolarize. As the cell membrane depolarizes, it opens a voltage-gated calcium channel, which causes calcium to flow into the cell, and that causes exocytosis of the insulin, which has been produced in the beta cell and packaged into these vesicles, and exocytosis. So remember this drawing. We'll see it later with another type of family of diabetes medicines called sulfonylureas, which affect this process and increase insulin secretion by the same process. All right, so now we're looking at a graph of physiologic blood sugar throughout the day. And you can see the blood sugar is pretty flat at night because you're not eating. In the morning, blood sugar rises when you eat, and then it comes back down fairly quickly, and it may start to up again, and then when you eat lunch it rises again, and it repeats this throughout the day. Whenever you eat, the blood sugar is going to kind of go up. So if you have a snack at midnight, here's your midnight snack. Now we see blood sugar and insulin superimposed on one another. So you can see as the blood sugar begins to rise when you eat, insulin is secreted and insulin rises. And then as the blood sugar starts to decrease, insulin secretion falls off. And so insulin follows, sort of shadows, the rise of blood sugar throughout the day. So we're going to see how important this normal physiology is as we're trying to give insulin to mimic the normal physiologic rises and falls in insulin throughout the day. Let's talk about the actions of insulin. What does it do? For our purposes, the main function of insulin, the main purpose of insulin is to allow glucose to come out of the bloodstream and get into the cells where it can be used. But it also has a lot of other actions in other tissues. In muscle cells, insulin stimulates protein synthesis and glycogen synthesis. In liver cells, insulin stimulates glycogen formation and increases triglyceride synthesis. In adipose tissue, insulin triggers triglyceride storage. In pancreas, as we've just seen, insulin reduces insulin secretion. And insulin also increases cellular potassium uptake, which is very important. There are a couple of instances where we need to be mindful of this. First of all, when we treat hyperkalemia, someone comes in with a very high potassium level, 6.5. They come into the emergency room, they're at risk of having cardiac arrest because of this. One of the treatments you might give very rapidly to get the blood potassium down is to give insulin. We also give that with an ampule of D50, which is a high glucose fluid. We do not give the D50 to lower the potassium. D50 by itself will not lower potassium. We do give D50, though, to offset the effect of giving all that insulin. If you give a patient a bunch of insulin, it's going to drive their potassium down, but it's also going to drive their blood sugar down, and that can be very dangerous. So we need to give D50 at the same time. We also need to be mindful of the lower potassium levels in someone receiving insulin when we're treating diabetic ketoacidosis. As we mentioned, diabetic ketoacidosis is associated with very high glucose levels. You can have glucose of 500, 600, 700, even up to 1,000 or higher. So Blood sugar is very high, and you treat this with high doses of IV insulin, given through a continuous IV insulin drip. Well, that insulin is going to get the blood sugar down, but it's also going to drive the cellular potassium levels down. It increases cellular potassium uptake and drives down the serum potassium. So when you give someone IV insulin for diabetic ketoacidosis, you often will put them on a potassium drip. They may come in with normal potassium, but you know you're going to be making that potassium low, and so you're going to give them potassium right off the bat. Let's talk about insulin degradation. What happens to insulin in the body? Well, insulin is broken down by insulin-degrading enzyme, which is also called insulin protease. Regular insulin, the insulin we all produce, has a very short half-life, about 5 minutes. But it's also metabolized in the kidneys and in the liver. So a patient with renal failure, the insulin you give them will last a lot longer. So imagine you have a patient with diabetes who is on insulin, and they've been pretty well controlled, and all of a sudden their blood sugar starts to drop. Or they start to tell you, well, I used to be using a lot of insulin, and all of a sudden I'm not having to give as much insulin anymore. Well, that may indicate that they're having renal failure, that the insulin that you're giving them is lasting a lot longer in the body, and so it's driving the blood sugar down too low, or they're just not having to give themselves as much insulin. So in that situation, you would want to check their creatinine and BUN and make sure that their kidneys are still working appropriately. So renal failure can cause exogenous insulin to last a lot longer. Let's also talk about the adverse reactions associated with insulin. What are the adverse effects of insulin? The three things I want you to remember are hypoglycemia, weight gain, and lipodystrophy. We'll talk about each one of those individually. First of all, hypoglycemia, low blood sugar. Obviously, if you give insulin, it's going to drive the blood sugar down. Well, this causes symptoms of tachycardia, vertigo or dizziness, diaphoresis, which is sweating, and also confusion and anxiety. Patients who get low blood sugar, get hypoglycemia, they really get used to this feeling. They can tell their blood sugar is low. They say, I just don't feel right, I'm sweaty, my heart's racing, I feel a little dizzy, I feel a little goofy and confused. They know what it feels like. In general, we want to avoid beta blockers in patients with diabetes who are at risk for hypoglycemia for a couple of reasons. Number one, beta blockers will mask the sympathetic symptoms of hypoglycemia. So they might not get tachycardic because they're on a beta blocker. They might not feel that way. They might not realize that their blood sugar is getting low, and so they don't know that they need to go ahead and eat something to raise their blood sugar. Beta blockers can also increase the risk of developing diabetes and can worsen diabetic control. So beta blockers, you can use them in diabetics, but you need to be very, very careful. The second adverse effect or adverse reaction of insulin that we talk about is weight gain. There are a lot of different theories of why patients with insulin or why patients on insulin get weight gain. One is that insulin itself has anabolic effects. As we mentioned, it causes triglyceride synthesis, it causes protein synthesis, it stimulates the body to produce a lot of these things that will cause weight gain. Patients who are on insulin will also get some relative hypoglycemia, so they may be eating a little bit more to prevent hypoglycemia. They don't want to get low blood sugar overnight, so they eat a little snack at bedtime. And they eat a little snack during the day, and they're trying to keep their blood sugar from getting too low, and as a result they're taking in a lot more calories, and so they're gaining some weight. The third adverse effect of insulin use is lipodystrophy, which means local atrophy or hypertrophy of adipose tissue. This is a harmless problem, but it can be unsightly. When a patient gives himself insulin over and over again, they're injecting the insulin into the adipose tissue in their belly or in their thigh or something like that. And that causes the fat cells to either atrophy or hypertrophy. It causes little divots under the skin or little lumps in the skin. This is more of a problem with insulin analogs, which we'll talk about momentarily, than it is with the regular insulin. The main treatment for this is to alternate injection sites. Don't always give it in the same spot in the belly. Kind of rotate it around. Use different places. The more places you can give it, the less likely you are to have lipodystrophy locally. Let's talk about insulin administration. How do we give insulin? Well, first of all, insulin has to be given as an injection. Now, why does insulin have to be given as an injection? Well, think about it. Insulin is a polypeptide. It's a protein. So we cannot absorb proteins orally. They're degraded and broken down into individual amino acids before they're absorbed. So any insulin that you were to take by mouth would be degraded and decomposed before it was actually absorbed into the bloodstream. So insulin is given as multiple subcutaneous injections, or sometimes as a continuous subcutaneous infusion via a little device called an insulin pump. Rarely in emergencies we use IV IV insulin. There was a product in late 2006 through 2007. It was an inhaled insulin called Exubera. This was widely touted. People thought it was going to change the face of diabetes treatment. We're going to have inhaled insulin. You'll never have to give yourself an insulin shot again. But it was taken off the market basically because there was not enough consumer demand. The sales were poor. The drug was very expensive, whereas injectable insulin is very cheap. And honestly, the inhaled insulin was no better than the subcutaneous insulin. It offered no therapeutic advantage. You also couldn't use it in any patients who were smokers or who had a history of significant lung disease, and there was a possibility of increased risk of lung cancer. So inhaled insulin right now is a non-starter. It's not on the market currently in the United States. So injectable insulin is all we have to offer.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide.
You've done it now, houseless.
I'm sorry, do I know you?
Are you kidding me? You're the jerk who wouldn't help me this morning, and now my patient is vomiting with severe abdominal pain.
Well, I'm sorry. As you can see, I am a very busy man, and I don't have time to help every insignificant intern that comes my way. What have you got for me?
2 Ensures and a dinner roll.
Fine then. Let's see what we got. Vomiting, pronounced thirst, decreased skin, turgor, confusion, abdominal pain, and excessive urine production. Seriously? This is what you need help with? Didn't you check her blood sugar levels? Your patient is in diabetic ketoacidosis. She needs insulin to reduce blood sugar and suppress the production of ketones. She also needs copious IV fluids for her severe dehydration. Fetch. Don't you dare bleed on my porch!
Okay, at this point in our lecture, I'd like to review some of the key points of what Dr. McGinnis has already mentioned, and maybe some of the key points that you would have read in your pharmacology review book. So if you turn to, first of all, to page 1 of your study guide, the section on diabetes mellitus basic review, there's that table comparing type 1 and type 2 diabetes. I want to make sure that you understand the cause is different in type 1 and type 2 diabetes. So in type 1, Dr. McGinnis mentioned that the beta cells are destroyed, and so there's no insulin production. And that contrasts that with type 2 diabetes, where there are still some beta cells, but it's an inadequate production of insulin. All right, so they're not functioning as optimally as they could. So there's not as much insulin, but also very important to note is that there's insulin resistance. The insulin that is present is not working very well in type 2 diabetes, and that's one of the main distinguishing differences between type 1 and type 2 diabetes. Let's look at quick review 1. Number 1. Why should beta blockers be used in caution in diabetic patients? So Dr. McGinnis mentions this before. We talked about how patients that are taking insulin can become hypoglycemic. And when they become hypoglycemic, they're going to have signs of hypoglycemia, including diaphoresis and tachycardia. Those are adrenergic symptoms. When you take beta blockers, you're going to interfere with your body's ability to generate a fight or flight response. You're not going to have the tachycardia. You're not going to have the symptoms of hypoglycemia. Consequently, diabetic patients may not know when they become hypoglycemic. Now, take note here, it doesn't say you can't use beta blockers in hypoglycemic diabetic patients. It says you have to use them with caution. And this is an important note because a lot of diabetics have coronary artery disease. And one of the drugs you need to take when you have coronary artery disease to reduce morbidity and mortality is beta blockers. So you can use them in diabetics, but they just need to be aware of the potential problem if they become hypoglycemic. Number 2, what effect does insulin have on potassium levels? So insulin increases the cellular uptake of potassium. So in patients that are hyperkalemic, in patients that have high potassium levels, we actually give insulin to reduce their potassium levels in their serum. The potassium shifts out of the serum and goes into the cells. Is this a great way to control potassium long term? No, it's a great short-term way to control potassium. High potassium is life-threatening. When you encounter it, you need to treat it very quickly, and one of the ways you can do that is with insulin in addition to sugar. If you just give insulin to a patient, their sugar is going to bottom out. So you give insulin plus sugar. Dr. McGinnis mentioned D50, which is a sugar dextrose solution. So you push an amp of D50, push 10 units of regular insulin, and that'll help to maintain euglycemia while lowering your potassium levels. Number 3, what would you suspect in a patient with hypoglycemia in a lab workup that reveals an absence of C-peptide? All right, so we saw how C-peptide is cleaved off of your proinsulin molecule. So when you have excess levels of endogenous insulin, as you might have with an insulinoma, insulinoma is a tumor of the beta cells of the pancreas, so you have a ton of insulin being produced. In that case, you would have a lot of insulin in your body and you would have a lot of C-peptide in your body. In this case, if you don't have the C-peptide, but you do have a lot of insulin, that means the insulin has come from outside the body. Somebody is giving themselves too much insulin, causing hypoglycemia. And so this is an example of a way fictitious disorder may present. That's called fictitious disorder. Number 4, describe the process by which glucose stimulates insulin release in the beta cells of the pancreas. So physiologically, this is very important to know. This is highly testable. This is also important to know when we talk about your oral diabetic drugs. Glucose enters the beta cell. It's metabolized, causing an increase in ATP that closes potassium channels. So the influx of glucose, the next step is the closing of potassium channels that causes membrane depolarization. Whenever you close potassium channels, your cell depolarizes. You see that with neurons. Anytime you close potassium channels, membrane potential increases. Right? You have a depolarization and action potential that takes place. And as a result, your voltage-gated calcium channels will open, allowing calcium to enter the cell. And this, whenever calcium enters the cell, that allows for exocytosis of a vesicle, in this case, a vesicle filled with insulin. Number 5, what disease results when a type 1 diabetic does not take sufficient insulin? Type 1 diabetes, they get DKA, diabetic ketoacidosis. Number 6, what disease results when type 2 diabetic has severely elevated blood sugar due to poor control of their diabetes? In general, they don't get DKA. They don't get diabetic ketoacidosis, all right? They don't make ketones because type 2 diabetics usually have enough insulin around to prevent ketone body formation. So they don't get DKA, but they can have problems. In a type 2 patient that has hugely elevated blood sugar, like in the 800s, these patients are going to exceed their kidney's ability to reabsorb sugar, so they're going to start urinating out sugar. As they urinate out sugar, water is going to follow. They get dehydrated. They get what's called NKHOS, non-ketotic hyperosmolar state. There's one way you're going to see this referred to, NKHOS, non-ketotic hyperosmolar state. The American Diabetic Association has another name for this. It's very similar, but it's HNS, which is hyperosmolar non-ketotic state. So same terms, just switched up a little bit. So something to be familiar with. Type 1, DKA. Type 2, HNS. Number 7, how is long-term glycemic control measured in patients with diabetes mellitus? In patients with diabetes, you should be checking a hemoglobin A1C about every 3 months. The hemoglobin A1C is how you measure the long-term control of diabetes. It is glycosylated hemoglobin. When glucose gets attached to a hemoglobin molecule in a non-enzymatic way, that creates hemoglobin A1C, and that's what we're talking about here. Number 8, insulin is normally administered subcutaneously. In what circumstances would you administer IV regular insulin? We talked about one of those circumstances just a second ago. We said in cases of hyperkalemia, you might give insulin with dextrose in order to reduce potassium levels. Another scenario where you give IV insulin is a hyperglycemic emergency, such as DKA or HNS. Number 9, what are the counter-regulatory hormones? Very testable, all right? Medical school, step 1 likes to test you on this one. Counter-regulatory hormones, these prevent the human body from becoming too hypoglycemic and in certain circumstances may cause hyperglycemia in diabetic patients. So these hormones that work against insulin are glucagon, epinephrine, cortisol, and growth hormone. So in scenarios where a diabetic patient has too much of these, it's going to raise their sugar levels and make them more likely to go into DKA or HNS. And the last question, what type of receptor does insulin bind to in order to exert its effects? Insulin binds to a tyrosine kinase receptor. That's its messaging pathway. It uses tyrosine kinase. All right, so that's it for now. We'll head back to Dr. McGinnis.
So we've covered the basics of diabetes, and we've covered the physiology and the effects of insulin. Now we're going to discuss the different formulations of insulin before we move on to how do we use it in specific treatment plans. So the goal of insulin treatment is to normalize blood sugar, which fluctuates during the day, according to what you've eaten and according to activity levels and hormones. We saw a graph of physiologic blood sugar fluctuations throughout the day and insulin fluctuations throughout the day. And our goal is to mimic that normal physiology of insulin going up and down throughout the day to try to keep the blood sugar under control without causing hyperglycemia or hypoglycemia. There are multiple insulin preparations. They generally differ based on onset of action and duration of action. So all of these different insulin preparations we're going to talk about, we use them often in combination to mimic normal physiology of insulin secretion and the fluctuations of insulin in the blood. That's our goal, is to mimic that normal physiology. And so we're going to talk about three main categories of insulin that we use to do that. First is short-acting or rapid-acting insulin. Second is intermediate-acting insulin. And third is long-acting insulin. So first up, rapid-acting or short-acting insulin. This includes regular insulin, insulin lispro, insulin aspart, and insulin glulisine. The four types, we have regular insulin, or sometimes called insulin R. This is packaged as 6 insulin molecules in a hexamer, in a package of six molecules together. There's also insulin lispro, which is basically human insulin that has a slightly modified amino acid sequence. A lysine and a proline have been reversed in position, and this provides for more rapid absorption, more rapid onset of action. There's also insulin aspart, which is a similar molecule with a different change in the amino acid sequence, and insulin glulisine, which also has a similar change in the amino acid sequence. All of these have very similar actions. They all work very quickly. They're all absorbed very quickly. We see these rapid-acting insulins are absorbed very quickly. They have their onset within about 30 minutes for regular insulin, and it peaks within 2 to 3 hours, and it lasts 5 to 8 hours total. And you have to give it about 30 minutes before you eat. With the other three, the analogs, the lispro, aspart, and glulisine, they have a much more rapid onset of action within 5 to 15 minutes. They peak more quickly. They peak within an hour, and they last 2 to 3 hours before they are degraded. And so you can give these much closer to mealtime. You can give them 15 minutes before you eat, or even when you eat, or even a little bit after you eat, which gives the patients a little bit of flexibility. Some patients on insulin may say, I don't always know when I'm going to eat. It's very inconvenient to say, well, I'm going to eat in 30 minutes, so I'm going to have to give my insulin now. Or if they go to a restaurant and they expect to sit down and eat, but there's a delay in their food coming, they've already given their insulin, and now they're getting hypoglycemic because they're waiting on their food. So it's much more convenient to give a type of insulin that can be given immediately before you eat or right after you eat. It's much more convenient and much safer for the patient. So these are all given around meals, the rapid-acting or fast-acting, short-acting insulin. All of these insulin analogs, lispro, aspart, glulisine, they all have about the same efficacy as insulin. They just work in a faster time period and they work for a shorter period of time. Next we'll talk about the intermediate-acting insulin. The main one here is called NPH, or neutral protamine hagedorn insulin. This is a very old drug. It's been around since the 1940s. This is basically insulin that's been conjugated with protamine. So NPH insulin, this conjugated protamine insulin, is less soluble, and that causes delayed absorption of the insulin. So it takes longer to start working, and it lasts longer in the body before it's degraded. And you can see from the image here that it has its onset within 2 to 5 hours, and it peaks within 3 to 8 hours, and it lasts anywhere from 4 to 12 hours. What you note from those numbers, that's a pretty broad window. It lasts in the body anywhere from 4 to 12 hours. NPH has a very inconsistent absorption. very inconsistent kinetics, so it's difficult to know exactly how a patient's going to respond to it. You kind of have to tinker with it and toy with it and try different doses. There are a couple of other insulin, intermediate-acting insulins to mention. One is insulin lispro-protamine. It's basically the same concept of conjugating insulin with protamine, but it's using lispro insulin. And they also make one that's insulin aspart protamine in a suspension. Neither of these are widely used. They're usually used in combination, as we'll see below. You'll also may hear sometimes of patients who are using products called lente insulin or ultra lente insulin. These are no longer available in the U.S. Lente means slow, and so these are slow-release insulins that are no longer used. They're off the market. Then we'll talk about some long-acting insulin preparations, specifically insulin glargine and insulin detamir. Now, insulin glargine is designed to precipitate at the injection site. So when you give the injection, it forms crystals right there at the injection site, and then the individual insulin molecules dissolve slowly over time and are released sort of as a time release. So it has an onset within an hour to an hour and a half, but there's really no peak involved. It's sort of a constant flat level of insulin that you see being released all the time. It takes maximum effect after 4 to 6 hours, and it lasts 24 hours or longer. The nice thing about insulin glargine is that you can give it once a day because it has no peak. It's not going to wear off. It's going to just continue in the body for a full 24 hours. So you can give it once a day. Typically, insulin glargine is recommended to be given at night, at bedtime. Although there's no real reason for this. This is just the convention. So you can give insulin glargine whenever you want. You can give it at the same time of day every day. I often tell patients, you can take it at bedtime if that's convenient for you, but if it's more convenient to take it in the morning, take it in the morning. Just take it at the same time every morning because it needs to be given at the same time every day so it doesn't wear off. Insulin detamir is very much the same thing. It works in a little bit different way. It doesn't precipitate at the injection site. Rather, it associates with albumin, and then it slowly dissociates, which allows that same kind of gradual, peakless release of insulin. And as you can see from the image here, there's a nice flat insulin curve without any peaks and without any troughs. It's just a constant release of insulin. So again, to recap, there are 3 main classes of insulin, 3 main types of insulin that they're split up based on their duration of action. We have the short-acting or rapid-acting insulin, which includes regular insulin, insulin lispro, insulin aspart, and insulin glulisine. We also have the NPH insulin, which is an intermediate-acting insulin, and we have insulin glargine and insulin detamir, which are long-acting insulins. Now it's time for our Angry Surgeon question of the day.
Which has a longer duration of action? Insulin glargine or insulin glulisine? Are you even paying attention? Glulisine is one of the shortest acting insulin analogs, and glargine is one of the longest. Why do I even waste my breath on you?
So how do we use insulin? This is where we get into the practical nitty-gritty of insulin treatment. In Lippincott on page 290, it talks about standard treatment versus intensive treatment. And personally, I find this kind of way of thinking about insulin a little bit simplistic. Some patients who have type 2 diabetes are on insulin along with oral medications, so you may be able to get away with just 1 insulin shot daily. They may just need a little bit of basal insulin. Some patients need 1 rapid-acting dose a day along with their largest meal. Patients with type 1 diabetes need much more intensive therapy. They may need 4 shots a day or sometimes 5 or 6 shots a day because they can't make any endogenous insulin. The only way you're going to be able to mimic that normal insulin physiology is to give them all the insulin artificially. So there's no right or wrong way to use insulin. The goal is to control the blood sugar. And if you're controlling the blood sugar well, it doesn't matter if you're following somebody's specific guideline. But there are some guidelines and some ways that are commonly used, and so we'll talk about those. Just remember that our goal is to mimic that normal insulin physiology without excessive hyperglycemia or hypoglycemia, which can be dangerous. Intensive therapy, using insulin very aggressively to mimic that normal physiology, has been shown to reduce long-term complications in the kidney, in the peripheral nerves, avoid diabetic retinopathy or damage to the retina. As I mentioned, there are a lot of different ways to use exogenous insulin to control blood glucose levels. This first image shows 3 doses of regular insulin given at meal times. Those are your prandial boluses of insulin. And then a single dose of NPH given at bedtime. So this is an intermediate acting insulin used as a basal insulin at night, and then 3 doses of regular insulin at meal times. You can see that there are large valleys between the doses of regular insulin in which no basal insulin is being given. So you can imagine you might get some hyperglycemia during those times. In this slide we see 2 doses of insulin being given daily, one at breakfast and one at supper time. Both doses consist of both regular insulin and NPH given at the same time. This could be as a mixture of 70-30, where you have 70% NPH and 30% regular, or they could be 2 separate injections mixed together in the same syringe. But the NPH given twice a day provides a more constant basal insulin, and the regular insulin is given as boluses with meals. The big downside to this is unless you give a 3rd regular insulin dose at lunchtime, you're still going to have hyperglycemia when you eat lunch because there's no insulin given to cover that. You can also use what are called insulin combinations or pre-mixed insulin. There are a lot of different options here. One of the most common is NPH and regular insulin mixed together, where you have 70% NPH and 30% regular. And so you can also have 50-50 NPH and regular. You can have Lispro and the Lispro protamine suspension we talked about. You can also have Aspart and Aspart protamine suspension combined. The dosing of these insulin combinations or these pre-mixed insulin can be very tricky. Usually you give about 2/3 of the daily dose in the morning and about 1/3 of the daily dose in the evening, and then you kind of adjust it based on the patient's response. Maybe the patient's someone who eats a big meal in the evening. They're not eating a lot of breakfast or lunch, but they're eating a big supper, so you may need to give them quite a lot of insulin in the evening. On the plus side, you can give these insulin regimens twice a day. So instead of having to take 4, 5, or 6 insulin injections daily, you can get away with 2 insulin injections a day. So it's very convenient for the patient. It just doesn't control the blood sugar as well. It's more difficult to control the blood sugar with premixed insulin than if you use what we call a true basal bolus insulin. So that's what we're going to talk about next. And unfortunately, this is not in Lippincott. Usually with a basal bolus insulin, you give a long-acting dose of insulin once a day. That's your basal dose. And then you give rapid-acting insulin in boluses at meal times and maybe at bedtime. In this slide, we see true basal bolus insulin. We have a long-acting insulin, glargine or dedamer, given at bedtime here, and that lasts throughout the day, and you can see it just tapers off a little bit before the next dose is given. And then you have the boluses of rapid-acting insulin, in this case using Lispro insulin with meals. And this pretty well mimics the natural insulin physiology. You have a little basal insulin all the time, and then you have sharp spikes at meal times. This is the closest we can come with exogenous insulin to reproduce that normal insulin physiology. The big problem with this is it requires multiple injections. If you get 1 dose of insulin, of your basal insulin, plus 3 mealtime doses and maybe a bedtime dose, that could be 5 insulin injections a day, which a patient is not going to be as crazy about. Sometimes patients will get anxious. They say, gosh, when I add up all the insulin I'm getting 150, 200 units a day. What they're not looking at is that their blood sugar is being more tightly controlled, so they're less likely to have any of those complications that we talked about. The other problem with true basal bolus insulin is to use either of the long-acting insulins or any of the insulin analogs that are short-acting, rapid-acting. These are all brand-name drugs, and so they're more expensive as opposed to regular insulin and NPH, which have been around for 60 or 70 years and are therefore much less expensive. Insured patients may have an easier time getting some of the brand-name insulins than your uninsured patients. So you have to take all these things into consideration. What is a patient willing to do? How well is a patient going to do taking 5 insulin injections a day as opposed to 1 or 2? What can they afford to do? So there are a lot of other things you have to consider with your insulin injections other than simply which brands of insulin you prefer to use. Other things you need to consider when you're doing adjustments in insulin include things like the timing of the insulin. When are you going to give it? How big are the meals that the patient's eating? And then what do you do when a patient is sick and they're maybe not eating as much? Patients on insulin are instructed in what we call sick day rules, so we'll talk about that. First of all, the timing of the adjustment, the timing of the insulin. If you have a patient who is having fasting glucoses that are very high, they get up first thing in the morning and their blood sugar is very high, what do they need to adjust? Are they adjusting their breakfast bolus insulin? Well, no, that's not going to do any good. Their blood sugar was already high before they had breakfast, so they need to adjust insulin before that. They need to adjust their basal insulin or their evening dose of NPH, because that's what's affecting their morning blood sugar. Now, say you have a patient who has a very high blood sugar just before supper. What do they need to adjust? Do they need to adjust their supper time dose of insulin? No. Again, their blood sugar is already high before they get to supper. What they need to adjust is their morning NPH, or maybe the bolus of insulin, the rapid-acting insulin that they give at lunchtime, because that is going to have more effect on what their sugar is throughout the day and affect what their blood sugar is at supper time. Now, what about a patient whose blood sugar is high at bedtime? What do they need to adjust? Well, should they adjust their supper time bolus of rapid-acting insulin, or should they adjust their NPH? Now, these are the patients you do want to adjust their supper time bolus of rapid-acting insulin, because that supper time bolus is what's affecting their blood sugar 3 or 4 hours later when they're going to bed. If you adjust their NPH, again, the NPH is lasting all night long. So you want to make sure that you're adjusting your insulin based on what's really going to affect the patient's blood sugar. Again, there's no exact right or wrong way. This is one of those situations that's more of an art rather than a science. You just need to have an understanding of what kind of insulin they're on and what the differences in timing of the insulin injections are going to make on their blood sugars later in the day. You make small adjustments. You don't need to rewrite their entire insulin regimen. You just adjust it by a few units here and a few units there, and then monitor carefully. See what their blood sugar is doing after you've changed their insulin. Have them call you back in 4 or 5 days or a week and report some blood sugar readings and see what's going on. Don't be afraid to give your patients huge doses of insulin if that's what it takes to get their blood sugar down. As long as you're not causing hypoglycemia, you should be okay. I've seen patients with type 2 diabetes, large patients. They have a high degree of insulin resistance. They need a lot of insulin. Their body's already making a lot of insulin and they're just not using it efficiently. So you can give them sometimes 150, 200 units of insulin at a time. Sometimes they need massive amounts of insulin. I saw a patient once who was on about 350 units of insulin daily. So it can be a huge amount of insulin that they're getting. And patients, as I said, can get very nervous about that, but sometimes that's what it takes to get their blood sugar under good control. Other considerations. Again, you have to think about the meal size. What do you do if a patient's taking small meals, eating a small breakfast? Well, they may not need very much insulin during that small meal. What if they're switching to a low-carb diet, or they're eating a meal that's very low in carbohydrates? Well, those meals are not likely to raise their blood sugar, so they may not need to give themselves quite as much insulin. What about a patient who skips meals? You know, a lot of patients say, well, I'll eat breakfast, but it's a small breakfast, and then I don't eat lunch, and then I eat a big supper. Well, you don't need to give them the same amount of insulin at breakfast and supper if their breakfast is very small and they're not going to be eating anything else throughout the day. If you give them a large dose of insulin at breakfast, they're going to get hypoglycemic. On the other hand, if you wait and you give them a large dose of insulin at supper time, that may be exactly what they need to control their insulin throughout the day. And then finally, we need to talk about the sick day rules, which is, again, something that's not found in your Lippincott book. You don't need to memorize the specifics of sick day rules, but be familiar with the concept. When you're sick, when you have any kind of medical illness, your blood sugar, your glucose, tends to be higher, and you may need more insulin. Very often patients won't feel like eating, and they think, well, I better not take my medicine, I don't want to get hypoglycemic. Unfortunately, even though they skip meals, their blood sugar may still be high, they still need their insulin. So these patients need to be instructed to check their blood sugars frequently throughout the day, even if they're not eating, even if they're not, they don't feel like they're hypoglycemic. They need to be checking to make sure that they're not getting hypoglycemic or hyperglycemic. And they need to understand the basics of their insulin. They need to know that they're on a long-acting insulin and they can't give an injection of insulin glargine and expect for their blood sugar to be lower in 30 minutes. They need to understand that it's going to last all day, and so if they give a huge dose, they're going to be at risk for getting hypoglycemic later in the day. By the same token, if they're on a fast-acting insulin, such as Lispro, they need to know that that's not going to last all day. They may give themselves a large dose in the morning, and then they need to be told to expect that in 2 or 3 hours it's going to be pretty much worn off, and they may need to give themselves more insulin. So they need to understand what their insulin is doing to their body. And one of the most important things for sick day use of insulin is do not let them get dehydrated. Tell them to keep hydrated, drink plenty of fluids, because if they get dehydrated and they get hyperglycemic, they're really high risk of developing diabetic ketoacidosis. So tell them to keep hydrated no matter what. And then one final topic before we finish. This is something else that's not in Lippincott. It's the issue of the dawn phenomenon, or something we call the Somogyi effect. So imagine you have a patient who's complaining that her blood sugar is high first thing in the morning. The fasting blood sugar is much higher than they are at bedtime. And they say, well, I went to bed, my blood sugar was 150, and I didn't eat anything all night, I was asleep, and I woke up the next morning, my blood sugar was 250. What's going on, doc? My insulin's not working. Well, what's the issue? There's a couple of things that could be going on. First, it may be something we call the dawn phenomenon. Normally, naturally, we release hormones such as cortisol in the middle of the night around 2 or 3 o'clock in the morning, and that is going to raise our blood sugar, it's going to raise our blood pressure, it's going to be able to help us get up and get going in the morning. So patients who are having a normal rise in blood sugar throughout the night, it may be that they need a little more insulin at bedtime to keep their blood sugar from rising. Or maybe they need a little more of a supper time NPH dose to keep their blood sugar from rising too much overnight. Then there's also something we call the Somogyi effect. This is a situation where their blood sugar is actually not getting high overnight, but it's getting low overnight, and they have a rebound release of glucagon and a rebound hyperglycemia. So, they wake up in the morning and their blood sugar is high because it's gotten down to 30 or 40 overnight, and they need to do something to raise their blood sugar overnight so they're not getting that rebound hyperglycemia in the morning. They actually need not more insulin, but less insulin overnight to prevent the overnight lows. So go back to your patient and think about it. How do you determine if this patient's having dawn phenomenon or a Somogyi effect? Well, one way to determine it is have that patient set an alarm and get up at 2 or 3 in the morning and check their blood sugar. If the blood sugar is low, well, that means that this is Somogyi effect. They're getting low blood sugar overnight, rebound hyperglycemia, and so you need to give that patient less insulin at bedtime, either less of their supper time NPH or less of their long-acting insulin, so that they don't get that hypoglycemia overnight. If that same patient sets the alarm and checks the blood sugar at 2 or 3 in the morning and it's normal or high, well, this means that this is dawn phenomenon. They need to get a little bit more of their insulin at bedtime to keep that blood sugar from getting so high overnight and to kind of counteract those normal hormones that are going to raise the blood sugar. No matter what you do, after you adjust their insulin, you need to have them monitor their blood sugar carefully, make sure that it's coming down in the morning, and make sure that they're still waking up at 2 or 3 o'clock in the morning a few times to check and make sure that that blood sugar is appropriate. If it's still getting too low, they need to reduce their insulin. If it's still too high, they need to raise their insulin. So these are just a few of the things you need to be aware of when you're giving patients insulin. And again, this is very much an art more than it is a science. You need to understand the science of how these insulins work, which ones are long-acting, which ones are short-acting, but you need to be sort of flexible and be able to individualize the amount of insulin that you give according to the patient's needs and how they respond to each insulin injection.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide. Number 1, which insulin can be given IV? So most insulin is given sub-Q in a day-to-day fashion, but sometimes you need IV insulin. In the cases you need IV insulin, you're going to either reach for regular insulin or one of your rapid-acting or short-acting insulin. So you can use your Lispro, your Aspart insulin, or your glulisine. So any of those can be given IV. Number 2, what are the 2 long-acting insulin preparations? These are insulin glargine and insulin dedamer. All right, it's important to identify which of your insulins are short-acting and which are long-acting. So make sure you know these terms and can categorize them appropriately. Number 3, in which type of diabetes is insulin required for treatment? So definitely type 1. You can't treat type 1 diabetes without insulin, right? But also, insulin may be required for type 2 diabetes. Now, type 2 diabetic, in general, you're going to start with an oral agent first. If that's not sufficient, you might add a second oral agent. If that's not sufficient, you have one of two options. Either add a third oral agent or go right to adding insulin in addition to the oral agents. And we're going to talk about that when we talk about the oral diabetic drugs. But type 1 diabetics definitely need insulin. Sometimes type 2 diabetics may need insulin as well. Okay, now Dr. McGinnis talked about dosing insulin and how insulin dosing is very individualized, not only by patient, but also by practitioner. And so this is sort of the art of medicine. Which insulin preparation do you decide to use as a practitioner for your particular patients? All right, so it's very hard to teach general rule of thumbs here with these. But let me just throw a few things out there that will help you understand or just have a starting point, so to speak, with insulin preparation. Number 4, it is determined that a patient needs to be started on insulin and a total daily dosage is calculated. Now you may be wondering, well, how do you calculate a total daily dosage? Again, just as a loose rule, this is not a uniform rule, but it's very common to use 0.5 units per kilogram. All right, so for a 100 kilogram patient, you might need to use 50 units of insulin over an entire day, divided up throughout the day. All right, very loose rule, needs to be individualized by patient. All right, but anyway, moving on. Assuming that the patient is going to be started on a mixture of NPH and R insulin, which is your regular insulin, what percentage of the total daily insulin is typically dosed in the morning before breakfast, and what percentage is dosed in the evening before dinner? This is important to know as a third-year medical student. So you can impress your interns and residents and attendings by knowing this information. So when you're dosing insulin, you take your total daily dose and you divide it up. So 2/3 of that is given in the morning before breakfast, and 1/3 of it is dosed in the evening before dinner time, or as Dr. McGinnis refers to it, supper time. So in your morning dose, 2/3 of your morning dose is going to be NPH, and 1/3 of your morning dose is going to be your regular insulin. All right, and of your evening dose, which again was 1/3 of your total daily dose, that evening dose, if you're using NPH and R, is going to be 1/2 NPH and 1/2 R. So again, just a loose rule to start from whenever you're treating patients with diabetes with insulin. Number 5, if a patient is on an insulin dosing schedule of NPH and R in the morning and evening, what dose should be adjusted based on the following findings? So this is highly testable, very important to know. So a patient presents with hypoglycemia prior to breakfast. All right, which insulin dose is supposed to be taking care of blood sugar at breakfast time? It's actually prior to breakfast time. It's actually the evening NPH. So if a patient has hypoglycemia prior to breakfast, you're going to have to reduce the evening NPH dose. The second one, hyperglycemia at lunch. Which dose of insulin is taking care of sugar levels at lunchtime if you're using NPH and R? It is the morning regular insulin takes care of the lunchtime sugar level. Hyperglycemia at dinner, if you have that, which insulin would you adjust? Your sugar level at dinner time is dependent upon your morning NPH, because that morning NPH is supposed to carry you through 10 or 12 hours through the day and get you through to dinner. So your sugar level right before dinner time is reflective of how well you did with your morning NPH dose. So if you have hyperglycemia at dinner or right before dinner, you're going to need to increase your morning NPH. Hypoglycemia at bedtime, in that case you would reduce your evening regular insulin dose. Number 6, again, this is one of these very loose rules, it's not a hard and fast rule, but number 28, as a general rule, when increasing a patient's insulin dose at a clinic visit, what is the most you usually would increase the total daily dose of insulin at the visit? Very loose rule, about 10 units of insulin. So if you have a patient that's on 60 units of insulin, it's poorly controlled, you want to go up, you're going to increase the total daily dose by up to 70 units of insulin. So you go up by 10 units is what most physicians are comfortable doing at one particular clinic visit. And then, of course, bring them back, a few weeks later and make sure that they're doing okay. Number 7, when dosing insulin glargine as basal insulin and insulin lispro, which is one of your short-acting insulin, with meals, what is the usual ratio of total daily glargine dose to total daily lispro dose? Again, another loose rule. Different physicians are going to tell you different things, and this does need to be individualized to your patients. But in general, if you're starting one of these regimens or switching somebody from NPH-R to Glargine and Lispro, about 50% of your total daily insulin would be Glargine. The other 50% would be Lispro divided between meals based upon when the patient had their biggest meal of the day. So it might be that they have 10% of their Lispro dose in the morning, and then 20% in the afternoon, and the other 20% in the evening. So of their total daily dose, 50% is Glargine, 50% is Lispro, and that 50% Lispro, of course, is divided between meals.
So now's a good time to pause the video and complete your in-session quiz, then restart the video and we'll go through the quiz together.
Hello, I'm Dr. Christopher Lewis. I'm one of the chief educators here at DIT, and today we're doing the in-session quiz for diabetes mellitus and insulin part 1. Differentiate the basic typical characteristics of type 1 and type 2 diabetes mellitus. Let's start with the age of onset. Well, in type 1, most patients are going to be young. In type 2, you're mostly going to see older individuals. However, we are seeing more young patients with this problem because of the obesity problem. Appearance. Most type 1 diabetics are going to be very, very thin, kind of wasted looking. In type 2, you're going to see more obese patients. Prevalence. Well, the prevalence of type 1 is relatively low. In type 2, it's increasing and relatively high. Genetics. It's less important in type 1, far more common of a problem in type 2. Families high in type 2 diabetes tend to want to continue to have diabetes in the family. Defect. The defect in type 1 diabetes is a beta cell destruction, whereas in type 2 you get more of an insulin resistance. Next, what is the goal of insulin therapy? Well, ideally you want to be able to mimic the normal insulin patterns that the body would normally do. What are the symptoms of hypoglycemia? Diaphoresis, shakiness and jitteriness, slurred speech, confusion, and tachycardia. Identify each of the following insulin preparations as either short-acting, intermediate-acting, or long-acting. Well, the short-acting insulins will include regular insulin, insulin aspart, insulin glulisine. The long-acting insulins will include Glargine and Detamir. And the only intermediate insulin there is the NPH insulin. How would you distinguish Somogyi effect from dawn phenomenon? Well, if you test the glucose at night around 2 to 3 a.m., if it's normal or high, then that's dawn phenomenon. If it's low, then you get Somogyi. If you determined that the type 1 diabetes mellitus patient's morning hyperglycemia was due to Somogyi effect, then what modifications in therapy would be necessary? Well, you can do one of two things. You can either do a bedtime snack, or you can decrease the long-acting insulin in the PM. How can a patient cut down on lipodystrophy secondary to insulin injections? Well, that's easy. You just move the injections around to different sites on the body. Or you can also change over to a regular insulin. What are the counter-regulatory hormones that raise serum blood sugar? Well, glucagon, cortisol, amphetamines, and growth hormone. Which insulin can be administered IV? Well, pretty much it's all of the short-acting insulins, and those include regular, aspart, Lispro, and glulisine. What type of cell receptor is activated by insulin? Well, that's tyrosine kinase. And that's the end of the in-session quiz for diabetes mellitus and insulin part 1.